this patient, we're going to extract a tooth 3.8. We start with articaine, local anesthesia with vasoconstrictor epinephrine 1 to 100,000. And as you see, I don't perform a full block, but just local anesthesia. I try to infiltrate the liquid under the periosteum to see a bleaching of the tissues. This is a procedure that takes place for about 2 or 3 minutes, so we need to take our time before we start our surgery, and this will make it feasible to perform the surgery without having a full block with the advantages we have already described. So we're gonna have to make a few little punches with our needle in order to block the area. We may need a little supplement of anesthetic during the surgery in some cases, but we usually can make it to have the whole intervention without a full block. We have to have a tension of the tissues so that we can see the area, and then we're ready for the incision. We use a 15C scalpel blade, an intrasulcular full thickness incision to the bone, and then the distal releasing incision. Before doing the incision, remember to go and touch where the ramus of the mandible diverges to feel the variable anatomy of each patient so that we know where the bone is. And then we will start in the area between the sulcus that divides the lingual and the buccal cuspids, and with a full thickness incision, we're going to do the distal releasing incision until the adherent mucosa, and then on the alveolar mucosa we can have a non-full thickness flap in order to prevent any damage to the buccal nerve. You see here, it's not a full thickness incision. Then we will start elevating our flap with a freer elevator, periosteal elevator. We use the sharp area and we start putting the concave part towards the tooth. But once we find the correct plane where we want to separate the tissues, then I flip the side and I tend to use it as if I'm going to open the pages of a book. So you see that I'm pushing towards the external area in order to open my flap. Once I find and I see the naked bone, then it's much easier to follow this path and to expose the bone completely. So I have my Langenbeck retractor on the bone, and here I'm trying to expose my underlying tooth. Always remember that this movement has to be done by flipping the tissues lingually, because we have to remain on the bony side in order to prevent any damage to the lingual nerve. So now we're starting to see the underlying tooth. Okay, so it's a gentle and delicate separation of the tissue, and always bear in mind to look what our assistant is doing in order to prevent that our elevator sinks in the soft tissues, creating a compression damage of the lingual nerve. Here you can use a curette, you can use a spoon, you can use any instrumentations to see the tooth. And the important thing is that we have enough vision to have the space to do the bone sectioning without any particular tension. So if you have any tension, you have to enlarge your incision, as we're doing now, in order to have a good vision of the bone without creating any tension. Because if we have tension, we will have sufferance of the tissues and a major risk of damaging the surrounding tissues. Okay, so now we have the correct vision, the protection of the lingual aspect, and we can start to imagine where we want to remove our bone, which is buccally to our 3.8 tooth. A round carbide bar on a fast straight handpiece under abundant saline solution, cold saline solution irrigation, and we create a bone removal, what we call a ostectomy of the bone surrounding the tooth till maybe just a little bit above the CEJ in order to see the crown of the tooth. We know that this is a young patient, so we're going to have not a big interference of the roots during the surgery. Here we use a piezoelectric instrumentation to remove some working space between the bone and the tooth and the roots. And you see that with this instrumentation, we are very, very conservative, and we manage to create space without losing buccal bone, which is vital for the best healing of our patient. And we know that we can use this instrumentation also close to soft tissues and vital tissues as nerves and vessels. And we can also go distally and also in some cases lingually without having to protect the soft tissues using the selectivity properties of this kind of surgery. So now we have created some space around our tooth, and we can test the luxating movement of our tooth, and we see that the tooth is already a little bit wobbly, so it already moves a little. And this is very useful to do before any tooth sectioning, because in case of apex root fracture, this will help us out in removing any root fragments that remain after our luxation. So in order not to force our pressure in the luxation movements, we decide to cut the tooth and to reduce the volume of the tooth in order to preserve bone. It is always very important to work perpendicularly with our fissure burr with the protection of our Langenbeck elevator, a retractor, in order to avoid any damage of the surrounding soft tissues, because we can have some burning issues of the soft tissues if we are concentrated on the tip of the burr and we don't look at the long part of the burr. So what we see that we have entered the pulpal cavity and the patient has had no pain response. In these cases, in some cases, if the patient feels a little bit of pain or has any issues, we can have and we can perform a intrapulpal anesthesia. So once we have created our separation that has to be a incomplete separation, we tend to complete the separation with a complete fracture of the coronaradicular aspect. You see that we have a fracture of the crown, and also we can have the fracture of a part of the root. In this case, the root hasn't completely been separated. Suction to see if we have any fragments of the tooth, and now the luxation can be completed and we can perform our extraction, always with gentle and delicate movements without creating too much pressure, which has no use in these kind of extractions. So a gentle mesiodistal luxation, and also we're going to find a luxation in the buccal lingual aspect. We see that the tooth is coming out, but there is still a little bit of interference, so using always a Fisher bar or a piezoelectric instrumentation, we can go and create a little bit more space buccally in order to have the correct movement of the tooth in its exiting area. So we see that the tooth is a little bit more out of its space, and with gentle and delicate movements we go and perform and finish our surgery. With a hemostatic clemmer forceps, we extract the rest of the tooth. Always look at our tooth to see if the tooth is complete, if there's no fracture, and we see that the terminal part of the roots was incomplete, and this is the reason of the easiness of the extraction. This is one of the moments when there is an indication, the best moments to extract wisdom teeth, because the teeth are not going to be very deep as in early germectomies, and the tooth is not going to be completely attached to the bone. Now, an important part of the surgery is going to remove the follicular tissue, the follicle of the tooth, and any granulation tissue, any inflammation tissue that is usually present distal to the second molar, where the pericoronitis inflammation had occurred during the previous months. Always try to tear gently this tissue in order to remove it completely, and always check distal to the second molar that no soft tissue is left behind, in order to avoid those late infections at 3 weeks after the surgery. You see that we have a little bit more material distally to the second molar. So with a mosquito, we tend to remove it, trying not to rip it, but just to pull it out with a gentle and delicate movement. And this is the soft tissue that we wanted to remove. Delicate and accurate suction. Always be careful with this suction procedure, because if we have an exposure of the inferior alveolar nerve, we can create a damage. Although we didn't damage it during the extraction, abundant and cleaning solution with saline cold solution, and then it's time to close our flap In this case, we're using a collagen sponge which tends to stabilize the clot in our cavity. This is a slow resorbing collagen sponge. We hydrate the sponge so that it gets a little bit bigger in the cavity, and then we are ready for suturing our flap. So we see that this kind of flap is a minimal invasive flap. It doesn't comprehend the papilla between the sixth and the seventh tooth. And it's very important now that the assistant, as we see, just gently flips the flap in order for the surgeon to go and apply the stitches. We don't have to push too hard on the bone in order to have the not to have ischemia of the soft tissue. So we see that the flap tends to go back in its original position if we have treated the soft tissues gently. This is a 3/8 needle with a synthetic monofilament 4-0, and we have a mattress suture in order to close the soft tissues behind the seventh tooth, in order to squeeze them and create a seal of the area. And you will see that when we close the knot, the two areas will tend to close completely behind the seventh tooth. And this is a suture that tends to prevent any pseudo-periodontal pockets, and have give a good periodontal healing distally to the seventh tooth, to the second molar. And then here we have the cutting of the two threads. And then we're going to apply single sutures on the releasing incision. You see that with the Langenbeck retractor, we tend to elongate the incision in order to parallelize the two soft tissue areas of the flap in order to recreate the original anatomy. And so we see that after we close already the first and the second suture, the wound is almost closed. The releasing incision, as you remember, was a little bit elongated, so we go to perform a second single suture of the apex of our releasing incision, and then we check to see if the threads are too long, and we check to see if we need one last suture or if everything is fine and the wound is closed. It is very important in this moment to see that the threads are not too long in order to avoid having any uncomfortable issues during the post-op surgery. And here we perform the 4 milligrams dexamethasone infiltration in the muscle to reduce the edema and the swelling of the area in the first hours of the post-op. And then our compression in order to check the hemostasis at the end of the surgery. Thank you for watching.